Dr. Smitha Pabbathi is going to present an update on breast cancer survivorship. Dr. Pabbathi is an academic oncology hospitalist and primarily cares for hospitalized patients at Moffitt Cancer Center. She also is the medical director of the survivorship program at Moffitt Cancer Center. So I'm looking forward to Dr. Pabbathi's presentation.
This way. Is that good? Thank you. Hey, Dr. Loftus, thank you. Thank you. Thank you, Dr. Loftus, and thank you, SMA. Oh, how do I, is it just the arrows? Okay, great. So I think what I hope to do by the end of this discussion is to have everybody in here have a better understanding of the definition of a cancer survivor and survivorship care, the essential elements of survivorship care planning, and specifically cardiovascular risks for breast cancer survivors and the recommendations we can provide our patients for their overall wellness and survival. So to start with definitions, there's multiple understandings or definitions that folks can think about and talk about, and many people believe you're a survivor from the moment of diagnosis, and this is what the National Coalition of Cancer Survivorship endorses. Others believe living 5 years beyond a diagnosis defines a survivor, likely based on the risk of recurrence. But for purposes of this discussion and beyond, what we're going to use is the functional definition of survivorship, which is really a survivor defined as a patient completing therapy with curative intent and transitioning to prophylactic or hormonal therapy. So regardless of the definition we choose, I think we can all agree that survivor's life is forever altered from the moment of diagnosis and treatment. In the early 2000s, the Institute of Medicine recognized that the importance of addressing the unmet needs of large and growing number of cancer survivors as they complete initial therapy. The period of transition from active treatment to post-treatment care developed as a critical time for long-term survivors. If care is not planned and coordinated, cancer survivors are left without knowledge of their heightened risks and follow-up plans of action. So previous to that report, IOM's initial trajectory was quite different. Patients were progressing through the cancer journey essentially to the end of life, and we used to think of this trajectory as a distinct linear phase. Once therapies are eventually exhausted and disease progresses, patients become in need of supportive and palliative care. However, that cancer continuum has evolved over time, and with the advocacy of all these national academies, survivorship represents a distinct period in the continuum to emphasize the importance of long-term follow-up and surveillance management of long-term late effects, rehabilitation, psychosocial care, health promotion in order to improve the care of our survivors. So when we break this period of survivorship down further, there's 3 distinct phases that emerge. The first is the acute phase, and this is focused on diagnosis and treatment. And we do a phenomenal job, just like Dr. Solomon and his colleagues have pointed out, with all the advances in care, and our focus is on remission. However, we need to do a better job of understanding the now what question following completion of primary therapy. We need to dedicate more attention to patients as they transition to the next phase of the cancer journey. And these are the extended and permanent phases of survivorship with regards to the physical changes, the psychological, social, and even spiritual changes that are unique to the diagnosis of cancer and treatment that can occur months, if not years, after completion of therapy. So because the needs to address this on a national level, 4 elements emerged in survivorship care as 4 pillars, and these pillars are meant to raise awareness and advocacy in clinical practice, education, but also research. So when we talk about prevention, we're talking about prevention of new second primary malignancies, because we know these patients are at risk for developing them higher than the general population. We're talking about surveillance for recurrence of their primary disease, and intervention and treatment of consequences of cancer therapy like lymphedema and neuropathy. And we're also talking about coordination of care, so better handoff to our family practice and internists. I'm an internist by training, so this is a particular point of interest to me. So we can keep our patients and our providers engaged in the overall wellness of our providers. So once thought to be a fatal illness, cancer is evolving into a chronic condition and lasts until recurrence or discovery of a second primary, at which time they re-enter the phase, patients re-enter a phase of survivorship care until the end of life. So as part of our initial evaluation in our clinic, when patients are referred to us from various home programs to our survivorship clinic, we do a comprehensive, personalized, risk-based assessment in the form of a survivorship care plan by taking a full history, a complete physical exam, but it also includes reviewing their treatment summary, surveillance recommendations for primary cancer, but also prevention for secondary malignancies and health promotion guidance. And this can be a powerful assessment as well as a powerful tool to keep patients engaged and empowered to be active participants of their care, to help coordinate with their primary care physicians. And this becomes particularly important because the sheer number of survivors is growing due to these advances of multimodal therapies and cancer prevention and screening leading to earlier detection. So as you can see here, the NIH data shows the prevalence trajectory for older cancer survivors in the US. So the anticipated silver tsunami, by 2040, they're projected to be over 24 million survivors. And for women, breast cancer is still the most frequently diagnosed cancer and the second leading cause of cancer death in the US. But as we can see on this graph that's specific to breast cancer mortality, overall breast cancer rates, although increased at 0.4% up until about 1990, have steadily, rapidly declined to almost 40% through 2015. So not all women, as you can see here, have benefited equally, as you can see the divergence between Black and white women beginning in the early 1990s. So as a result of improved survival in an aging population, breast cancer is evolving into a disease of older survivors who face an important new set of challenges in the healthcare setting. One of these challenges is cardiovascular disease. Among others, this study was undertaken to describe the leading causes of death among older women diagnosed with breast cancer. So over 60,000 women were followed in this study for many years, and as you can see here, at about 10 years following diagnosis, the risk of cardiovascular-specific mortality exceeds that of breast cancer-specific mortality, making cardiovascular disease the primary cause of death in the study population. That becomes an increasing concern as breast cancer patients are surviving longer due to these advances in therapies. So our focus really needs to shift into more of a global understanding of their wellness and understand that the risk of cardiovascular disease may take a priority in the long-term care of these patients that have been treated for breast cancer. So why is that? We think that's because there's a hypothesis called a multi-hit hypothesis, where breast cancer patients have a reduction in cardiovascular reserve to begin with. And at diagnosis or prior to diagnosis, and these pre-existing conditions are heightened with the direct effects with adjuvant therapy and underlying indirect effects like deconditioning and weight gain that can occur during therapy. And these collectively these changes may leave the patient more susceptible for further cardiovascular insult and place breast cancer survivors at higher risk for premature death and cardiovascular mortality. So when we talk about cardiovascular disease, the three main ones we're focusing on is coronary artery disease, heart failure with reduced ejection fraction, and heart failure with preserved ejection fraction. So when we first look at coronary artery disease, we can see the progression of this healthy artery as it progresses and results in ischemic injury. And one of these treatments that's been implicated is radiation therapy. We know from some time that radiotherapy can be harmful to the heart, and this article in 2013 examined breast cancer patients undergoing radiotherapy over years. Among over 2,000 women in the study that were followed with an average dose of 4.9 gray, developed coronary artery disease, and you can see here that there's a linear relationship in the mean dose to the heart, suggesting that radiation therapy can be directly causative for ischemic events. With all the advances in radiotherapy, however, moving forward, this may be less of an issue. Another therapy to contribute to coronary artery disease is endocrine therapy. So analysis of pooled data show the longer duration of AI therapy is associated with hypercholesterolemia. And the increased risk of hypercholesterolemia can contribute to plaque deposition, resulting in likely faster progression of coronary artery disease. So heart failure is another process we worry about. This is a normal heart on the left. And there is some emerging research that heart failure with preserved EF will be a concern for breast cancer survivors, but we still need to know more. So our focus today is going to be on heart failure with reduced ejection fraction that's most associated with anthracycline-based therapy and trastuzumab. So this could acutely happen with therapy, but what we're focused on is the long-term or late effects where these symptoms, women have, patients that have survived their disease have symptoms years after completion of therapy. In this study of over 12,000 women that were followed after completing therapy, and as we can see here, the cumulative effect of anthracycline-based therapy with trastuzumab puts patients at much higher risk for heart failure years after completion of therapy. So what does this mean for breast cancer survivors? So that is what we know with the basics of cardiovascular disease for women with breast cancer. As women are surviving longer and longer due to these advances of therapy, what it ultimately boils down to is when we're caring for these survivors, what we have to keep in mind is they have a higher risk of overall morbidity and mortality. They have increased risk factors for cardiovascular disease, such as obesity, hypertension, dyslipidemia, and exercise intolerance. And in breast cancer survivors greater than 65, cardiovascular disease is the leading cause of mortality. So how do we prevent and treat this patient population with respect to decreasing the risk of cardiovascular mortality, as well as breast cancer-specific mortality? We believe a combination of things with weight control, physical activity, diet quality can reduce cancer recurrence and cancer-specific overall mortality, but we also believe that the synergistic benefits of this multi-component intervention could represent an optimal approach to offset these cardiovascular risk factors or disease in breast cancer survivors. So a recent meta-analysis revealed the benefits of exercise independent of diet and weight, except for individuals with a BMI greater than 35. breast cancer events were defined as breast cancer recurrence or a new development of a cancer. And what it showed is that exercise decreases breast cancer recurrence and breast cancer specific mortality as well as overall mortality. So if we know that exercise decreases breast cancer specific mortality, what about cardiovascular specific mortality in breast cancer survivors? And this study shows the exposure of exercise associated with decreased incidence of cardiovascular events in non-metastatic breast cancer patients. So in this study, close to 3,000 patients were exposed to about 9 metabolic equivalent tasks per week. And the things that were assessed years following years in follow-up were coronary artery disease and heart failure events. And patients that met the 9 med hours per week or greater had a reduction in cardiovascular events independent of anti-cancer therapy. And patients that met these 9 med hours per week had reduced cardiovascular events independent of age, pre-existing hypertension, diabetes at diagnosis. The only difference here is that women with a BMI greater or equal to 35 did not have that same benefit. So we may need to look closer at diet and weight reduction in combination with increased activity. So the diet recommendations really come from the breast cancer recurrence or with respect to breast cancer recurrence and breast cancer overall mortality. So multiple studies emerging or have emerged showing the higher blood levels of carotenoids from fruits and vegetables are linked to lower breast cancer risk, especially in hormone receptor negative breast cancer patients. So what about diet recommendations to reduce cardiovascular events in breast cancer patients? One of these was the Women's Healthy Eating and Living Study, the WELL study, that tested the effect of diet low in fat, very high in vegetables and fruit and fiber. So over 3,000 pre- and postmenopausal women were randomized to an intervention arm and a control arm and followed for over 7 years. And recurrence-free survival for this population did not differ in those 2 arms. But the Iowa Women's Health Study, however, found that diet plus exercise intervention after 5 years of follow-up in the breast cancer group had a reduction in all-cause mortality and cardiovascular-specific mortality in older survivors. So what does this come down or boil down to as far as concrete recommendations we can provide our patients that are breast cancer survivors to decrease their risk of cardiovascular disease, but also reduce their risk of cancer-specific mortality? And I think that the best way to do it is pretty much give them a prescription. I do this with all my patients and recommend that we be as lean as possible without being underweight. Oh, sorry about that. Exercise for a minimum of 150 minutes of moderate intensity per week, limit sedentary behaviors, limit processed meats and red meats due to the carcinogenic effects of those processed foods, consume a minimum of 2.5 cups of vegetables and fruits, and diversifying that consumption with a variety of fruits and vegetables, and choosing whole grains over refined grain products, and limiting our alcohol to 1 drink per day.